What I've tried to do is come up with those key, most important things that you need to understand for neuro, the things that nurses need to know to be on top of neurological cases, and a lot of that's not very complex at all. It can be as simple as this, you know, when cardiac patients sleep, it's good. When neuro patients sleep, it's bad. Those types of concepts we'll try to bring forth too to help you with your neurological patients. So let's do a quick review of the neurological system so that we're all on the same page. First of all, we want to remember that the central nervous system is your brain and your spinal cord. All right? An important thing to understand about this slide, the diagram of the brain, is to look at the circulatory system. Do you notice that this particular structure right here is very unique in the body? What is that called? That is called the circle of Willis. I don't know of any other area in your body where you have a circular connection of blood vessels. What is the purpose of the circle of Willis? Collateral circulation. That's exactly correct. So that if there is a clot or if there is a hemorrhage or rupture in the brain, blood flow can be restored or maintained to the brain because of this collateral circulation. I used to have an argument with someone that I taught with in the past about what's more important, the brain or the heart. Well, let me just tell you that if your heart's pumping but your noodle's gone, you know, the lights are on but nobody's quality of life is something that, you know, she would always win on that argument. Your heart can be pumping, you can be alive, but if you have no cognitive function, what is your quality of life? What is your purpose in life? Well, that's a whole ethical issue. But this collateral circulation issue is very helpful in the brain. It's also how they can do surgeries like a carotid endarterectomy. Remember when we talked about in cardiac the plaques in the carotid arteries? And they cross-clamp that, they cut it open and remove plaques. How come the patient doesn't have a stroke or an ischemic event when they're cross-clamping this while they're doing surgery? That's why. Collateral circulation, blood flow up the left side. It's very protective for the brain and it's very unique. So I like to point that out on this slide. All right, the peripheral nervous system has to do with the cranial nerves and the spinal nerves. Now, for Block 2, you do not need to memorize the cranial nerves. And I'm going to tell you something about myself. I don't have them memorized. I've not ever been able to do it. There is a pneumatic for it. You do need to know it in Block 4, and you need to know it for state boards. But if you asked me to do that for you right now, I would be unable to do it. I would also be unable to report each one as whether it's sensory and motor or just one of those. So I'm disclosing that to you, and I'm letting you know that I'm not testing you over that in Block 2. So you don't need to put your memory on that one until Block 4 or boards. You could get a question on it in boards. In the process class, I will go over a neuro assessment that assesses all the cranial nerves, and that you need to know. You can always look up what the abnormality is and determine which cranial nerve is involved. And that's what I do when I practice. I'm just being honest with you. For some reason, that's not something I've ever been able to commit to memory. Now, the spinal nerves are the ones that come off your spinal cord. All right? They are the ones that branch off from the spinal column out to the body. And they do provide motor and sensory innervation for your muscles. Right? So if I was to say I had a C7 pinch or impinging nerve over there, I would be assessing on that particular patient what is their movement, what is their function, and what is their sensation on the under part of their arm in these two fingers. All right, so that's how that information is helpful to you. Understanding that the peripheral nerves, you have one on each side. They innervate your muscles. They provide motor and sensory function. If they're damaged, you're going to see problems on the side where the damage is. If you have a bulging disc and it's pushing on one of your lumbar nerves, right? You'll get sciatica. You'll have pain and possibly numbness and tingling down your legs. Some of you already have this. You know what I'm talking about. An important concept when assessing and dealing with neurological patients is symmetry. Symmetry is very important. That you compare one side to the other. There should be symmetry. A way to pick up neurological problems is to find problems with one side and not the other. Establish a baseline, right, with your assessment, and then, oh my gosh, now I'm noticing a change, and symmetry is a key concept with neuroassessment. All right, the autonomic nervous system, you know I have a particular love and joy of trying to help students understand the autonomic nervous system, and you've received my form with too many words on it, but tell me how to make it better. It's a one-pager I'm still in progress with. The autonomic nervous system is the part of the nervous system that provides for you all these things that you don't have to think about. Your breathing, your heartbeat going up or down as needed, the digestion of your food, right? Those types of things are all controlled by the autonomic nervous system. And you've been exposed to those concepts in the pharmacology class when we talk about things like beta blocking drugs, right? Beta, for instance, are autonomic nervous system fibers. Beta 1 fibers innervate the heart. You have a sympathetic and a parasympathetic fiber. Those are part of the autonomic nervous system. It provides homeostasis. It makes your heart rate go up and down and balance as needed. You do not have to think about it at all whatsoever. And we can give medications which affect the autonomic nervous system to get what we want, but a lot of times we get other side effects that we don't want. So I'm trying to pull together for you that knowledge that you've already been exposed to with the autonomic nervous system. Are you getting that? Some of you getting that? Okay. It's one of those types of things where you're going to study this for years. And each time you study it, you're going to learn a little bit more. And you're going to understand it a little bit better. My charge to you is don't give up on it. It's a complex concept, but it's worth understanding. So keep working on it a little bit at a time. It will get better over the years. It will take years to totally get on top of it. All right. Also important with review of the neurological system is talking about cerebral spinal fluid, or CSF. And this diagram shows you about the production of CSF in the choroid plexus, and then it shows the travel of CSF. Its job is to bathe the nervous system and provide nourishment, the central nervous system, the brain, and the spinal cord. So when CSF is produced, it's going to travel through the ventricles of the brain. I'm not talking about the heart, but we use the same term, ventricles. It's going to travel through the ventricles of the brain, up around the cortex, down the cord, and back up, and it gets reabsorbed. That's what happens with CSF. So if the patient has a spinal abscess and the flow of CSF is obstructed because of an abscess or something like that, they will develop hydrocephalus. You're familiar with that term. Most people understand water on the brain. Okay, so the CSF is important. It's got a lot of sugar in it. It helps nourish the brain and spinal cord. It's constantly being produced, 20 to 25 cc's per hour, and constantly being reabsorbed, right? How much do we have at any given time? 125 to 150. Why am I telling you that? Because sometimes we do procedures for patients, like lumbar punctures, and afterwards the patient continues to leak CSF. How do we know? When the CSF hits a white sheet, it makes a yellow halo around the drainage. Why do I care? Because if the patient's leaking CSF and they leak too much, they're going to get horrible headaches, right? Light sensitivity, and they're at risk for developing an infection because there is an opening, there's a communication with the real world and the space. That's not supposed to be touching anything. It's not supposed to be open. So we worry about that. We'll talk more about that as we go into the courses today. All right, a protective mechanism in the brain, the blood-brain barrier. There are very unique cells that are tightly put together that protect the brain, so that when circulation goes through the brain, some stuff can't get out of the bloodstream and into the brain, like antibiotics. So that's supposed to protect the brain from toxic substances, right? That's what the purpose is. That's why the maker designed it, or at least that's my interpretation, was to protect the brain. So we have these really tight cells that don't let a lot of things through to protect the brain. But guess what? If you get a brain abscess, it makes it really difficult to get needed antibiotics to the brain. It can be very, very difficult to do so. Now it's interesting because some things are excluded and some other things get a free ride. Look what gets a free ride right through the blood-brain barrier. Those things which we like to partake of for pleasure, perhaps. Alcohol and nicotine. There's no obstruction on the blood-brain barrier from those substances. They get a free ride ticket right in. Okay? Other things, like antibiotics that a lot of times we need to get through, are excluded. So this affects treatment options for people who have neurological problems. If we need to get chemotherapy, if we need to get antibiotics to the brain, sometimes we have to put a special port or a special access device into the brain, and it's underneath the scalp. An example would be an Ommaya reservoir. They will bore a little hole, put a tube down into the brain, attach it up here to the skull, close the scalp, and there'll be a port, much like the venous access ports. And they use those for administering antibiotics and chemotherapy. Nurses don't do it, okay? That's intrathecal medication. Have you heard of that word before in Block 1? The intrathecal route of administering medications is into the brain. This is a challenge for us. Now, patients that do have diseases that end up in the brain, oftentimes it's because there's been a disruption in the blood-brain barrier, or because there's been a breach in the integrity of the skull, right? A head injury, a skull fracture. Okay. All right. Diagnostic tests or procedures that we can do for patients who have neurological problems. An angiogram, that's where we're shooting dye. We're looking for pictures of blood vessels. This could tell us if the patient has a brain aneurysm. We talked about that in cardiovascular. We talked about when they usually burst too. All right? Cerebral aneurysms, you remember that? Yes, during sex. That's usually when they burst. So they die happy. Hopefully they die happy. Lumbar puncture. If we're doing a lumbar puncture, what are we trying to collect? Cerebral spinal fluid. So we can collect in the lumbar or cisternal areas for cerebral spinal fluid. We send that off. It should be clear, colorless, and it should be full of sugar. If it varies from that, it tells us there's something wrong. If the sugar's all gone, guess what? You probably got a bacteria in there. You'll find the bacteria and the sugar's all gone. Why? What does bacteria eat? Sugar. That would be like consistent with a bacterial meningitis. All right? If the patient has a viral meningitis, we see a high elevation in protein, but the sugar's normal. Why? Viruses don't eat sugar. Exactly. So CSF lets us know something about infection, meningitis, encephalitis, those kinds of things. It also could let us know if the patient's had an intracerebral bleed. If you do a lumbar puncture and you get blood, it could mean that the patient's bleeding up here. But remember the flow of CSF? That blood will end up down below too. The only caveat to that is if the patient has had a traumatic LP. If the doctor's in and out with that needle a lot and you're seeing blood coming out, then it's probably not going to be a pure specimen. It'll have blood in it because it was a traumatic puncture. So we have to take that into consideration. All right, electroencephalogram, that's a picture of the brain electricity. It's very similar to an EKG. An EKG is electrical activity of the heart. An EEG is electrical activity of the brain. So if the patient has seizures, if they're trying to follow up on seizure disorders, they'll a lot of times do an EEG, or if they're trying to diagnose the patient as brain dead. When they do an EEG on a brain dead patient, the lines are all straight. You're not going to see any activity. Okay, we'll talk about that more in the other class. MRI are done, if you work neuro, especially in critical care, you will be taking patients to MRI almost every single day you work. They do an MRI before the brain surgery. They do an MRI after the surgery. They do another MRI the next day. If the patient has a change in level of consciousness, they do another MRI. You will know all the people in MRI very well. Okay? It's more expensive. It gives a little bit better data than a CAT scan. We'll talk about the utility of CAT scans in diagnosing strokes. Brain attack protocol, or stroke protocol these days is that patients who have symptoms, signs and symptoms of a stroke, get a CAT scan within 30 minutes of getting into the ER door. That is the standard. We'll talk about how that's used. It's less expensive, so this is the test they're usually going to do. Doppler studies can tell us about blood flow, impaired blood flow, and a biopsy, of course, is taking a piece of tissue to see, what's going on with it. All right, things that happen with aging. The brain gets smaller, it doesn't weigh as much, it becomes fibrotic, you have less connecting neurons. Unless you work on it, that's why they're talking about doing all the brain games and all those types of things, even with our patients in the nursing home, helps keep their brain viable and alive. Less connections between the neurons, more atherosclerosis, which means impaired blood flow or ischemia to the brain, memory loss, and we know which one it is. Which memory loss do we have with aging? It is short term. If you've ever worked long-term care, you know that the patients tell the same stories over and over and over and over and over, and you have to act like it's the first time you've ever heard it. That is so wonderful, and you're thinking, I've heard this 15,000 times. But, that's their experience. So the long-term memory remains, the short-term memory, you could have just told them, we're going to keep you NPO for a test today, and every time you see them, you've got to tell them that because they've forgotten. The other thing that slows down are their reflexes, right? The cat goes in front of the car, here's you, right? The cat goes in front of the car, your elderly person, it's a dead cat or rabbit, depends on where you live. So the reflexes are slower. It used to say that our elderly population were the best drivers. I think reality has finally caught up. You know what I'm saying? Watch out. It's snowbird season in Arizona. Our population in my city has doubled. Yeah. All right. Things that can contribute to neurological problems. Trauma. This could be our young people who think they're invincible. We've all been there. Some of us are still there. Tumors, and that's one of those worst case scenarios. So people come and tell me they have a headache. I'm like, how long have you had a headache? If you've got headaches that are unresolved, get your head scanned. Get your head scanned. Let's rule out the worst possible scenarios. You might have a tumor or an AVM. Let's make sure that we don't have those issues. Strokes. Strokes can be ischemic or hemorrhagic. We'll talk about that a little bit. Metabolic disorders. Remember when we studied liver? We talked about how the buildup of ammonia can cause a neurological problem. Hepatic encephalopathy, something that's happening in the liver that causes brain problems. Well, that's what it means when we talk about metabolic disorders. Is there something else that's causing the brain to not function properly? That can be related to renal failure, liver failure. And you see, it's not that there's anything truly wrong with the brain. It's that because there's a buildup of substances from another disease process, another organ that's failing, we have the presentation of neurological problems. Right? Infection could be meningitis, encephalitis. Which encephalitis is big for us here? Mosquitoes.
West Nile.
West Nile. Okay. Could be drug related. The patient started on a new pain medication. Can that cause a change in the level of consciousness? Absolutely. Okay. Drugs can do many different things, especially to elderly patients and such. Surgeries, and that just depends on where they're cutting, what they have to remove, what types of tumors, or genetic abnormalities. Some patients have what I was referring to before, AVM, arterial venous malformations, AVM. It's like a big knot and tumor of arteries and veins. And it acts like a tumor, causes pressure, causes headache and pain. What they're pretty much doing with those now is just sclerosing the vessels, the entry and exit points, so that it becomes a mass that's not alive. And then it shrinks down, do you know what I'm saying? But diagnosing that would be done with angiogram. It would find what looks like a tumor, but oh my gosh, it's just all blood vessels. and that's an AVM, an arteriovenous malformation. Treatable, totally treatable. All right, causes of brain injuries. And again, I'm going to skip through some of this. I'm not going to go into the complete detail of these slides. I just want to get the key concepts across to you. If you don't have enough oxygen in your system, your brain is one of the first things that complains. So, what happens to a patient who doesn't have enough oxygen? We see a change in the level of consciousness. They can become confused. They can become comatose. So hypoxia manifests itself in the brain very quickly. All right. As far as other brain injuries, we can have vascular disorders. We're going to talk more about those. We've already alluded to what they are. Trauma, head-injured patients, infections, tumors. These are all things that can affect the brain itself. An important concept for you to understand is the Monroe-Kelly hypothesis. When we talk about adults, we have a skull or a vault. It does not give and take. That's very different than in a newborn, isn't it? In a newborn, their sutures are not sealed in their skull, and they have what we call soft spots or fontanelles. So, if you have an infant that has an increase in intracranial pressure, their head will get big because the sutures are not sealed. An adult can't do that. So when we talk about the brain and its housings, the three contents you have are brain, blood, and CSF. If any of those components increases, the others must decrease. And if they don't, your patient will die. Why? Because this is a vault. This is not going to have any give to it. And what happens is as the pressure increases, your brain will start to push down over the one hole, the foramen magnum, right? And your brain will herniate down through that hole and cause brainstem damage and death. So having increased intracranial pressure and knowing how to assess that is very important. But this is why it's such a big deal in adults. There's nothing we can really do. This is static. This isn't going to change. So if something is having a problem, we have hydrocephalus for unknown reason. We have a bleed into the brain. The brain is swollen because they've had a head injury. If any of those components go up, the others must go down. We must control that, or the worst case scenario is they'll die. Compensation occurs only to a degree. Decompensation, of course, would mean they're going to die. All right, so herniation syndromes are very bad. That's all I'm going to say about that. All right? They're very bad. You can read the slide and see they're very bad. Herniation syndromes kill people. All right, let's talk about a few of the ways that we can get to herniation syndromes or problems. Cerebral edema, swelling of the brain. An easy way to think of that is a head injury. If the head is injured, it's going to swell. We have an external injury. Another way to think of that is a stroke. If the patient has an ischemic or hemorrhagic event in the brain is going to swell. That's why we don't know. You'll hear the doctors say to family members of people who've had strokes and head injuries, we don't really know what we've got here yet. It's going to take a week or two for the swelling to go down, and then we'll be able to tell you a prognosis. We'll be able to tell you what we think is going to happen. But even so, they're not God. Don't steal a patient's hope. Don't steal a family's hope. All you can do with a neurological patient is say where they are right at this moment, and that we hope that will continue to improve. Retraining for brain injuries can happen for years, and patients can improve for years. So my advice to you is never steal the hope. Don't give them unfounded hope, but don't steal their hope. Initial injuries, we're going to have to wait a week or two before we really know how bad off they are. Hydrocephalus is water on the brain. This picture tells 1,000 words. So let's see if I can get the lights down for you just a little bit so you can see this picture. Okay? Now, with hydrocephalus, we have collection of fluid, right? And in an infant, their skull is soft and can enlarge. So that's why the babies don't die. If it's us, we would die. Now, I don't know if you're aware of the fact, but when you have fluid collected in an area and you shine a light on that fluid, it will illuminate. So what you're seeing here is an infant who has a light behind his head, and that fluid-filled space is now illuminated. So where is the brain? The brain is smashed down, right? The brain is smashed down because of all the fluid collection. In an infant, then those fontanelles aren't going to be flat or sunken like when they're dehydrated. They sink when they're dehydrated. They're flat when they're normal. What do? They're going to bulge. So that would be very serious. Hydrocephalus. How do they treat hydrocephalus? They put a shunt. They put a shunt. If you can find the cause and take away the cause, great. If meningitis is the cause, clear the meningitis. Hydrocephalus will go away. If it's for an unknown reason, they have to put a shunt. They put part of it here in the ventricle, they tunnel it underneath and put it in the peritoneal cavity. As the pressure increases here, the fluid will shunt down into this cavity and be reabsorbed by the body. Okay?
Can they do that for adults too?
Yes, they can do it for anybody. And there is a group of people that are elderly that have hydrocephalus. There's a group of people that develop that. Now, the thing with kids is, as they grow, the shunt will displace itself, and they'll have to get another one. And they also like to stop working a lot of times and get plugged up. So how do you think you would know if the shunt isn't working? If it's an infant, their head's going to swell. If it's an adult, they're going to start having confusion, headaches, pupillary changes, nausea, vomiting. Those are all early signs of increased intracranial pressure. Okay? All right, manifestations of brain injury. Changes in the level of consciousness. We'll talk about the Glasgow Coma Scale in the next class. Those are some assessment tools that we use. Let's just suffice it to say that 15 on the scale is great. That's hopefully all of you. Hopefully you're not 14. I mean, you're like a little confused. 3 is pretty much dead. All right? 3 is pretty much dead. Pupillary changes we see as we have increased intracranial pressure. We might see abnormal motor responses, hyper movements, flaccid movements. We'll talk about that more later. Reflex issues and changes in vital signs. That's huge. What we see is a change in vital signs when the pressure in the brain goes up. The systolic blood pressure specifically raises very high. The diastolic gets really low. We call that widened pulse pressure. Why does it happen? Why does it happen? When you think about the amount of pressure in the skull and in the brain, how much pressure does the heart have to overcome to get blood up there? A lot. So therefore, the systolic blood pressure becomes very, very high. Now, in order to drain the brain, in order to get the fluids back out of the brain, what has to happen so that we'll have that siphoning of blood out of the brain? The diastolic pressure drops very, very low. So if you see a widened pulse pressure, 180 over 40, 180 over 40 would be suggestive of increased intracranial pressure. The fact that the systolic becomes so high, it has to overcome the pressure in the brain. The diastolic becomes so low so that the brain will drain. That's suggestive of increased intracranial pressure. Now the other vital signs are kind of squirrely. The heart rate will usually drop because of increased pressure on the respiratory center, not the respiratory, but the heart rate center on the brainstem. And the respiratory can go high or low. Neuro patients are weird that way if you haven't taken care of them. High or low. And the temperature in neuro patients can do either one, high or low. Strange. Very strange. All right. I just want to talk about this for just a second. We could talk about it all day long. It's that sort of ethical issue of what happens when we save people and what types of conditions people can be in. And all I need to say is one name. Terry Schiavo. Right? You knew what I was going to say. Someone that has had an issue with their brain, has been resuscitated and saved, but now is questionable. The lights are on, is anybody home? They have reflexes, they have vital signs, but they're not there. And my question a lot of times is, have we done any favor to the patient or the family? I don't know. In the critical care, sometimes we call that the cabbage patch row, where we have these patients that are there, but they're not there. And we have families trying to decide what to do and things. It's very, very difficult. I hope you're never placed in that situation. So we can have patients that end up in a chronic vegetative state. Or we can have patients that end up brain dead. And this is also very difficult to explain to a family. You have a family member, and it could be a young person who was in a car accident, who as a result of that was saved, but they're brain dead because they had not enough blood flow to their brain over time because of their injury. They look alive. They're on the bed with a breathing machine, their chest is rising and falling. They occasionally have a jerking movement, which is not purposeful, but they look alive. If we were to take them off the breathing machine, guess what happens? They don't breathe. They don't move their chest, they don't breathe, and they die. Okay? If we were to put an EEG on them, it's flat. No brain waves. Very, very, very difficult for families, especially if it's a younger person. So we have to give them time. We have to give them time. Sometimes we'll have someone that's brain dead that will keep that way in the unit, alive on the ventilator for 2 or 3 days to let the family deal with that and come to grips with that. Because we want to be able to offer them the option for donation if they want to do that. Do they want to donate organs? And that's a really hard thing too sometimes. You know, if you're working in the OR, you have a brain dead patient come in, you basically put them under, open them up, take out all their goodies, close them up, and they're gone. You know what I mean? It's a difficult thing to deal with. So, brain death, if it happens, know that all of your hospitals have protocols and policies for that. Most require 2 different tests to determine brain death, must be documented in the physician's record. One can be EEG. Another one can be removal of the ventilator support and draw an ABG after so much time. Another could be cold calorics. They squirt ice water into the patient's ear. The response that you expect in a patient whose brain is alive is they get nystagmus. Their eyes do this. In a brain dead patient, they don't do anything. Okay, so there are a list of acceptable diagnostic tests to determine brain death. It's never easy. It's not easy to be the nurse. It's not easy to be, of course, the family in this sort of situation. If you work in critical care, you will deal with it. If you work in other areas, you may or may not deal with it. All right, treatment of brain injury. Number 1, and this is going to come through to you in every section we deal with today, airway. Airway. Why? If the patient loses their level of consciousness, what happens to the airway? It can be compensated, right? Or it can be decompensated. It can be not patent. It can be a problem. When we relax and we become not awake, a lot of times the patient's airway will become obstructed by their tongue. So somebody just said, open the airway. Yes, we have to make sure we open the airway. And a lot of times we position these patients on their side, because when we position them on the side, the tongue falls forward. Less of an issue of obstruction. All right, I'm not going to go through this whole list in great detail because, again, in the constraints of time. We will be doing anything we can to reduce or prevent IICP, increased intracranial pressure. One thing that you may not be aware of is what happens to blood vessels in response to elevated CO2. That's a patho-related thing, so I am going to share that. If your patient is retaining CO2 because their airway is compromised, their blood vessels in their brain and their whole body will vasodilate. And if your blood vessels vasodilate in your brain, what happens to the pressure up here? It goes up. So do you follow the concept that if we controlled that patient's ventilation and made them breathe too fast on purpose, and we made them blow off extra CO2 on purpose, what would happen to the blood vessels? they would vasoconstrict. And that's what we do with patients who have increased intracranial pressure in critical care. We overventilate them on purpose. We want the CO2 below 35. We would like it between 25 and 35 because that will cause the patient to have vasoconstriction and that will decrease intracranial pressure. All right, we're going to monitor that pressure. We can put a brain drain or a ventriculostomy where we actually put a tube down inside. We can measure how much the pressure is in the brain. It's supposed to be 0 to 15. Okay, we can monitor that, and we can actually remove CSF as needed in critical care, just so you've heard about that. Treatment of hydrocephalus, doing all these types of things is general list. Again, I'm not going to go into the great detail in the constraints of time today. All right, brain attacks, very important for you to know about this. This is the third leading cause of death in the United States. Two different types, ischemic and hemorrhagic. Before we go into ischemic and hemorrhagic and break those out, let's remind ourselves that the risk factors are there and present. Some are modifiable, some are not. This list is almost completely identical to the list that we look at for the development of heart disease, atherosclerotic heart disease. So, diabetics need to do what? Control their blood sugar. We talked about that last week. Patients who have hypertension need to keep their blood pressure controlled. If they don't, what are they at risk of having up here? A stroke. It's huge, right? Some of us come along with genetic traits and such that make us more at risk, but let's certainly try to control the things that we can. All right, 75% of the patients that you're going to be taking care of that are having a CVA are having an ischemic event. And that means that there's an interruption in blood flow to the brain. It could be because there's an embolus. Okay? It could be because there's an embolus, or it could be because of atherosclerosis. Either thing is possible. What is a thromboemboli? That's a blood clot that's moving and obstructing flow to an area of the brain. So 75% of the time that's what you've got. The other 25% of the time you've got a vessel that's ruptured and it's bleeding into the brain. That's an intracerebral hemorrhage. If you did an LP on that patient, you're going to get what? Blood. You're going to get blood on that patient because that's going all around their brain tissue and into their CSF, right? Now, when I got out of school, the standard treatment for any patient that came in with signs and symptoms of a stroke was to start a heparin drip unless they got worse, and run it and unless they got worse. That was standard of care. Okay, what do you think of that? Yeah, about 1 in 4 of our patients got worse. Why? They were a hemorrhagic stroke. And when we gave them heparin, they bled more. And some of them actually died. Now, why wasn't I thinking logically at that particular time? I have no idea. But that was standard of care for many, many years until all of a sudden the American Heart Association said, you know what? Every patient that comes through our doors that's having the signs and symptoms of a stroke is going to get a CAT scan within 30 minutes. What will a CAT scan tell you? They will tell you if it's bleeding. The CAT scan will identify a hemorrhagic patient immediately. And guess what? That patient is not then going to receive heparin because that would kill him. Now, why didn't any of us think of that? I have no idea, but at least practice has progressed to the point now of that's the protocol and that's why. Now, signs and symptoms of a stroke. I won't ask you to memorize these separately at all in neurological, but I will point out some of the differences that you see in a hemorrhagic stroke. When you have blood coursing over your cerebral cortex and in your CSF, it causes meningeal irritation. That patient will have a headache. They will have neck stiffness. They might have sensitivity to light. They may well tell you it's the worst headache of their life. They will show up and have similar signs and symptoms as a patient who's ruptured an aneurysm. Okay? And it could be an aneurysm that's ruptured that's caused them to have a hemorrhagic stroke. It's very possible. So there are some things that are unique to a hemorrhagic stroke. I won't make you memorize them separately. What you're used to seeing are those signs and symptoms that come along with an ischemic stroke, where the patient has unilateral issues. Remember I talked about symmetry? All right, they have unilateral issues. If they have a stroke up here on the right side of their cerebral cortex area, their motor deficits will be where? On the left side. That has to do with the cross of the motor pathways in the brain. Depending on whether that stroke is above or below the tentorium will tell you what's going to happen with your cranial nerves. In many of those patients, you'll have cranial nerves deficits on the side where the stroke occurred, and motor deficits on the opposite side. Okay? It just depends on the level of the stroke and where it occurs, just so you have some idea. Your patient may be drooling. Your patient's face may be drooping. They may have pupillary changes. They might not be able to swallow at all. They might not be able to move their arm and leg on one side of the body, or they can't feel it. Very dramatic things that happen. Why do we want to know if it's ischemic or embolic? Because those patients may be eligible for thrombolytic drugs. If you watch the Discovery Channel, Discovery Health Channel, they often show a program where they administer thrombolytics to a patient who's had an ischemic event, and he shows up and you know he can't move his arm and he can't do this. They give him thrombolytics and he's okay. Wow, that's profound. Can you imagine? Before that, patients would end up completing their strokes and they would have those deficits for the rest of their life. So it's very profound, the treatment and the progression. One simple thing, doing a CAT scan on admission when looking for strokes, following up diagnostically on strokes to determine appropriate treatment. We only give heparin or thrombolytics to those patients who've had ischemic events. All right, brain attack protocol, early CTs, determines treatment. We talked about that. O2, IV. You've heard that from me before. Airway is important. We're going to be looking at that. Meds are only going to be given if it's ischemic. Now there are other medications that could be given. We'll talk about it in the process. A common medication given to stroke patients, either kind, dexamethasone. What kind of drug is that? That's a steroid. Very good. You remember a lecture last week. It ends in SONE. It is a steroid that is very, very good for decreasing inflammation in the brain and nervous tissue like the spinal cord. Right? So you would see that med possibly given. Why do we need to control hypertension? Decrease the bleeding. Decrease the damage. Now, patients that have had a stroke, whether it's ischemic or hemorrhagic, are at risk of developing seizures. When there's damage to the brain tissue, there are areas that can sort of pop off and be irritable. And that would be what we call a seizure, an uncontrolled neuronal discharge from a place that kind of takes everything over. That's a seizure. That's possible. And we're watching, are they getting better or worse? If you have a stroke patient, you're doing neuro checks. Every hour, every 2 hours, every 4 hours. Establishing baseline is critical. Where are they, and are they getting better or worse? Are they staying the same? What's going on? And you can't wait. If a neurological patient all of a sudden has a decrease in level of consciousness, you got to do something now. You cannot wait and watch it. You cannot do that.
What would you do?
Usually if you're working in a critical care, you have a PRN order, an as-needed order for MRI or CT if the patient has a change in level of consciousness. We want to assess them and make sure that, especially if they have increased intracranial pressure, is their neck in alignment? It can be silly little things. Is their head a bed up? Is their neck in alignment? Those are things which facilitate draining the brain, making things better for the patient. They've been laying down flat, well, that's bad for them. If their neck's contorted to the side, that can actually increase intracranial pressure. So you do assessment, do the things that you can do. If the brain is swelling, is there anything you're really going to be able to do about it? Nope, that's a call a doctor. We don't have any special equipment that like shrinks it down. Yeah. All right, concussion, not necessary for you to memorize this slide in any detail. Let's just say that in a concussion, the patient will have injury to their brain, some bruising. But it's microscopic. It's not going to readily show up on a CT or MRI. Do you follow? Concussion. The patient might lose consciousness for a little while. They might not remember what happened. They might have a headache and some irritability. And what we do is that we will want that patient to be monitored. So if they bring a child to the ER who got hit in the head with a rock, or they fell, or something like that, we're going to send them home with a list of things they should be checking over the next 24 hours. Wake your child up every hour on the hour for the next 24 hours and check these things. Do they know where they are? Do they know who they are? Right? Orientation, level of consciousness. They may or may not ask them to check pupils. Do they remember what happened? Just checking them. Baseline established in the ER, continuing to check that patient. Are they having a headache? Are they throwing up? All those different types of things. So head injury monitoring is critical. Contusion, that's a worse bruise. That one will actually show up on the CAT scan. We'll see some bruised or little microhemorrhage areas that macro. You can see them on the scan. And this patient might have actually neurological changes. Level of consciousness might be decreased. We might have cranial nerve deficits like pupillary changes, like they can't do the circle 8 with their eyes, like when they smile, part of their face droops. Those are cranial nerve deficits. They might not be able to speak properly. Okay, these types of things are more severe, and the patient would need to be monitored for seizures and other issues. All right, coup, contra coup injury. Just in case you get this on one of your reports or histories, this is common in car accidents and trauma, where the patient maybe was an unrestrained victim, and they actually hit their forehead on the windshield, but then when they slam back in the seat, they have that injury. Or this could be a restrained victim as well. They don't necessarily have to have impact on the frontal area in order to have a coup, contra coup injury.
I might have learned is to shaken babies.
Yes.
Okay.
Yes, you could have that with shaken babies, especially if they go like this, forward and backward, that as the brain wobbles around inside the skull, it's going to get bruised on the front and the back because it's moving and it's having impact inside. Yeah, that would be exactly the same sort of thing. So there's an injury as the brain flies forward, and then there's an injury as the brain falls back. So that patient would have frontal and occipital damage. If they shook them this way, then they would have damage on parietal, both sides. So that's called coup, contra coup. So looking for opposing injuries. But yes, that would be exactly what you would see in shaken baby type syndrome. It just breaks your heart. It's probably one of those reasons I never did peds. I just couldn't handle it. Okay, I'm also not going to ask you any specific questions about epidural, subdural, cerebral hematomas. What I want you to know is, if the patient has a collection of blood in their skull, there's a problem. We'll start there, right? If there's a collection of blood in the skull, there's a problem. That will do what? It will increase intracerebral, intracranial pressure. If blood goes up, the other areas must go down. The point this becomes a problem is when the patient starts showing signs and symptoms of increased intracranial pressure. They have a headache. They start to throw up. They're having pupillary changes. If it's an epidural bleed, which is an arterial bleed, which is faster than a subdural, which is a venous bleed, then you've got to make some changes really quickly, or your patient will herniate their brain onto their brainstem, and they'll die. Do you follow? So the concept is what's important in block 2. If your patient's bleeding in their brain because of an epidural or a subdural damage, an arterial or a venous damage, and this could happen in a car accident, you know, their head impact, it rips one of the vessels and they start bleeding. Or Ronald Reagan fell off of a horse. I don't know if you remember, he had a subdural and it didn't show up right away, it showed up later. He had a slow venous bleed. Okay? So these things you just want to think of, okay, is there enough blood collecting that we're going to have increased intracranial pressure? That's the significance. Now the intracerebral hemorrhage is the hemorrhagic stroke. It's the same thing. That's just a picture of a hemorrhage. And that will end up in your CSF and everything. It'll put blood out everywhere. So, key concept. If you have a collection of blood in your brain, watch the patient for signs of increased intracranial pressure, changes of level of consciousness, headache, nausea, vomiting, pupillary changes. If that's what you're seeing, they're going to have to evacuate. They will have to evacuate the hematoma. Not fun. Don't like this in critical care. Sometimes they will do this at the bedside. They will make a burr hole at the bedside. They do it with a hand drill. Don't like this. Nurse's job, hold the head. Anesthetize the skull. Cut it open. Drill, hand drill, burr hole. This is what I get to do. Hold the head so it doesn't wobble. But does that save the patient's life? We have to be able to evacuate the hematoma. If they leave it in there, it looks like a piece of liver. It sort of coagulates and becomes like a little piece of liver, and the immune system will eat it up. If it's left in there, it eventually will go away. But if the pressure is increasing a lot, they have to evacuate it. All right, I'm going to skip this. Epidural is an arterial bleed. More serious, right? If something's bleeding from an artery, it's more serious. Subdural bleed, venous, can occur very slowly and over time. Ronald Reagan. Intracerebral bleed, that's like a hemorrhagic stroke. Okay? What do we care about with all of these? Are they causing increased intracranial pressure? Is the patient symptomatic? Worst case scenario, if increased intracranial pressure is not treated, the patient dies. Simple. All right, meningitis. Several different types of meningitis. In Block 2, I'm not going to go into all the different details of all the different types of meningitis. Let's go over some of the key concepts. How do we diagnose meningitis? The patient comes with symptoms. What types of symptoms? Headache, stiff neck, light sensitivity, throwing up, fever. Those are all very common. Excellent. The patient will be like this. You try to put a pillow under their head, it doesn't work. They're still like that. Very suggestive of meningitis. That's because of what's called nuchal rigidity. The tube, the neural tube is irritated. Patient will be like that. Sometimes you put the pillow here. It's like, okay, let's just support him how we can. So if we take the patient's CSF, that's how we're going to diagnose meningitis, right? If it's bacterial, what are we going to see in the CSF? Low sugar and bacteria. That's how we diagnose it. It might come out looking cloudy. Remember, CSF is clear and colorless. If it's viral, it's going to come back with high protein, and the sugar will be normal. If it's fungal, we're going to come back with low sugar. And what are we going to, because we know fungus among us loves sugar, and we're going to see fungal particles. Now, a common one that you're going to see for meningitis in a certain patient group, HIV or immunocompromised patients in our area come with disseminated coccidiomycosis. Oh my gosh, that's a big word, Mary. What do you mean? I mean valley fever that's gone from this to the brain and the spinal cord. Disseminated means it's gone everywhere, and that's very bad. It's very difficult to heal up. But that's what you'll see in this area for fungal meningitis, disseminated coccidiomycosis. Common in HIV patients, common in immunocompromised patients. Remember, coccidiomycosis, the bug for valley fever, is in our dirt. It's all over the place here. If you're healthy, you don't get it. If your immune system's suppressed, you could get it. All right, some of the other signs and symptoms that we see with meningitis. We'll talk about Brudzinski's and Koenig's in the next class. These are assessment things that you can do to confirm nuchal rigidity. Cranial nerve deficits, nausea, vomiting. You hit the main ones. And that's the patient who's going to get that LP right in the ER. They want to be sure what they need. Some of these require isolation. Okay? All right, this is a picture of a nurse helping with, or a healthcare provider, I'm not sure, helping with lumbar puncture. That is hard. That is a hard thing to assist with. Look at the position the patient has to be in. What did I just tell you about how they like to lay? The nurse's job is to make sure that patient stays in a fetal position. When we put them in that position, it opens up the lumbar so that a needle can be put through to access the space for getting CSF. So the nurse has to keep them in that position. Make sure they pee first. Make sure they pee first. You have to hold them in that position. The other thing that you have to do is, once they get the needle in, you have to hold the manometer. You have to hold the tube that measures the pressure in the CSF. So you're cradling them and holding the tube. It's one of the hardest procedures to assist with, in my opinion. I drip sweat when I do it.
Why don't they just do it like they're going to do spinal anesthesia and just have it sit there and curl?
I don't know, but I think the movements are probably more controlled if they're laying on their side with somebody holding them than if they were sitting up. And we definitely don't want to cause any damage to the spinal cord. If the patient's sitting up and then all of a sudden they decide to lay back and slam back, they'll cram that needle right through their spinal cord. So I'm thinking that in patients who have nuchal rigidity, irritation, and that sort of thing, it would probably be a lot more dangerous than on a pregnant woman who doesn't. They're getting epidural anesthesia for pain control. That'd be my guess. You can control it better. Remember, if there's a needle in there and you all of a sudden are sitting up and you slam back, that'd be way bad. Okay, this confirms some of our findings for some of the issues, and it's a symptomatic management in addition to getting them the right antimicrobial agent. Meningitis does not usually cause a lot of long-term problems. It's usually not a big deal. People usually recover from it and are okay. That's the general thing. All right, let's talk about brain tumors for a few minutes. Again, just the most important concepts. I'm not going to ask you about any of the different types, any of the different cells, or anything like that. What I want you to understand is if you got a brain tumor, you're going to have signs of increased intracranial pressure, such as headaches. What else? Nausea, vomiting, pupillary changes. Right. It's the same signs and symptoms, but caused by something else. Now, what we need to find out is the tumor. Is it benign or is it malignant? That's really important. A benign tumor is usually encapsulated. It usually has a coating or a covering. And as it grows, it pushes the other tissue out of the way. So that when they go in and they resect it and cut it out, there's a good chance that the patient's function will remain intact. Do you understand what I'm saying? They won't be losing a big hunk of their brain and the function that's associated with that. If you have a malignant brain tumor, that one has fingers and tentacles. It eats through the tissue. It branches out all over the place, causing destruction. When you have to resect a malignant tumor, you got to cut out the whole chunk of the brain. There isn't anything that's going to return to that space. That function is going to be lost. Can the brain rewire and regrow? Yes. Can we retrain? Yes. The best results happen in children. Children are the ones who recover the best from metastatic brain, or not metastatic, sorry, malignant brain tumors. They recover the best. Now, I just used that word metastatic. What does that mean? That means a cancerous tumor that's spread from another location. So let's talk about that for just a moment. When a patient has a brain tumor that's malignant, they are going to try to find out if it's metastatic or not. Is it primary? Did it start here? Is that the only place where the cancer is? Or is it metastatic, meaning there's a primary tumor in the lung or a primary tumor in the kidney which has moved to the brain? Brain is a common site for metastatic cancer growths. All right, so key concepts. All I really want you to understand is if a patient starts to grow a tumor in their brain, they're going to have increased intracranial pressure. You know the signs and symptoms. You got to know that. You got to know it for block 2. You got to know it for block 4. You got to know it for boards. And you definitely need to know it for working. Very important. If it's benign, it's going to be encapsulated. It pushes the tissue out of the way. You can take it out. That tissue can refill the space. Function can return. If it's metastatic, it eats through everything. There isn't a way for that tissue to be preserved. If they have deficits because of I'm saying metastatic again. Malignant. Cancerous. Yes. Sorry, I'm confusing those words. If they have symptoms because of a malignant tumor, when they resect that, the patient is not likely to gain function back. We are just trying to stop the growth of the tumor. Did I say it right?
Yeah.
Okay. Question?
Just tumor and meningitis are very, very much alike. It's through the test that you find out which one.
The patient can show up with similar symptoms related to almost maybe 10 different neurological problems until they do the CAT scan, until they do the lumbar puncture, until they do an assessment. Because a meningitis patient is going to have nuchal rigidity. They're going to have neurological irritation. They're going to have a headache. So they have things that a brain tumor patient won't have. So there are some things, but it's very difficult to say with assessment alone. That's why you need the MRIs, the CAT scans, the CSF, those other types of assessments and diagnostic tests to come up with a diagnosis. All right. So those signs and symptoms are common with increased intracranial pressure, yes? Okay.